Alright, I'm Nina.
I'm Isaac.
Steph.
Ryan.
And we're going to get into this discussion. So let's start by going over the recognizing relevant clinical data. I'll read history of present problem. William Butch Welka is a 72-year-old male with a history of heart failure, COPD, hypertension, diabetes type 2, and dementia who has been hospitalized for exacerbation of heart failure 3 times in the past 6 months. He is now a resident of Pineville Estates, a local long-term care facility, and for the past 4 months, because his dementia progressed and his wife Rita was unable to care for him. When Rita visited Butch this morning, she reported to the nurse that he is more confused and is very concerned because he's easily angered. He insists that he sees his friend Roger, who served with him in the Navy, is in the room, but he died 10 years ago. Rita approaches the nurse station with tears in her eyes and states, "What is happening to my husband? This just isn't like Butch to act like this. Please do something to help him." Okay, personal and social history. Butch has been married to Rita for 51 years. They have 3 adult children who visit him weekly. Rita comes to visit Butch every day after work. He was a salesman for 35 years before he retired. Butch believes he is at Pineville Estates for rehab, but his family is concerned that it is no longer safe at home if he were alone, and Rita is awarded guardianship due to his declining mental status. So the first thing we have to figure out is what data is relevant from the present problem.
Obviously confusion.
Yeah, he sounds pretty confused.
I think we need to look at specifically what the present problem is. And the present problem is that he's got a confusion because his dementia and his COPD and his heart failure, all that stuff is old. That's what they're dealing with. They've been dealing with it for a long time.
Right.
But currently the problem is that he's got confusion, hallucinations, agitated easily. I think those are all listed as symptoms of delirium in our ATI textbook from this year for the mental health portion of the textbook.
Agreed.
Yeah, totally. Okay. And like you said, those are all kind of like the symptoms of delirium, right?
Mhm.
Okay. What about like his social history? Is there anything we need to be aware of there, you think?
Yeah, I think it's important to note that he's no longer safe in his home. Might be important to note that Rita's also awarded guardianship, so she'll be helping make some of his decisions. He does know where he's at, so he's oriented the place, if not anything else. So that kind of does show that he's disoriented, but there's some mental capacity there to know where he's at. And then, as mentioned, Rita has guardianship, so might be making some of those medical decisions and might need to rely on her for some information.
Okay, cool.
Definitely.
Anything else we can think of for a present problem or social history right now?
Not from what's given in the text, I don't think the information is provided.
Okay,
Mhm.
awesome. Alright, let's move on. It's giving us some vital signs to look at. So temperature is 99.8, pulse is 60, respirations are 16, blood pressure is 115/72, and his O2 saturation is 96 on room air. There's also a pain assessment, so it looks like he's able to stand and move, but he has dull pain in the lower back that was rated 4 out of 10, and it is, quote, always there. So it's asking us to look at relevant vital sign data. Right off the bat, I'm thinking his pain, it's 4 out of 10, even though he says it's always there. I think it's important we take that into consideration as relevant data.
Yeah, because it'll affect his mood and his overall communication.
I think the temperature is also important to note. While it's not super high, I think I remember reading in our patho book that older adults typically run a little bit lower. So definitely want to take a look at that elevated temperature and potential for some infection there.
Do we think the blood pressure is
Because he is diagnosed with hypertension, it is kind of strange that it's low.
Yeah, you would expect to see the opposite usually. Okay.
He is medicated, but usually they keep him a little bit higher than that.
Yeah.
If he takes a little low.
Okay. Sounds good. Next up, we have a mental status examination. His appearance, he's dressed in t-shirt and pants. His pants are urine soaked, wearing a sweater even though it is summer. That's a little odd, so right off the bat, we should probably include that. Motor behavior, ambulates with a walker, shuffling gait. Speech is clear. Mood and affect, he's pleasant except when talking about being at Pineville Estates, becomes agitated. Anxiety increases and angry. Emotionally labile, and he can become easily angered. Thought process, seems like he's generally coherent. Thought content, he's preoccupied with not wanting to be at Pine Estates and talks about how they are not helping him, wants to go home so he can hunt and get his hunting license. Perception, kind of was mentioned earlier, he is reporting seeing his friend Roger, who is dead, but there's no other current evidence of hallucinations. And insight is poor, he doesn't understand why he needs to be there, unable to recognize his own deficits of functioning, and judgment is poor. It says he's alert and oriented to person and place, not oriented to time or purpose, believes it is 2017. Short-term memory is impaired, but long-term is fine. He's pleasant when spoken to, hesitant to initiate conversation, and he did make a comment that if he doesn't get out of here soon, he might just walk into traffic. So let's just go down the list one by one. I kind of already mentioned appearance. He's wearing a sweater even though it's summer, and the pants being soaked in urine would definitely be relevant data.
Yeah. Possible incontinence and wearing a sweater in summer is an example of his cognition.
Yeah. Or decreased cognition.
Yeah.
What
Could
about?
also be a physical symptom. You could be feeling chills.
Oh yeah,
That's
His
another good
temperature
point.
goes up, and that could cause him to put a sweater on.
that's a really good point. Okay, we can include that. What about his motor behavior?
Shuffling gait and then using a walker. I mean, that shows some signs of impaired mobility. May place him at a little higher risk of falls. Reduces safety in the facility.
Totally. His speech is good. Mood and affect. It does sound like he's just really agitated. Whether that is
And high anxiety.
high anxiety, whether that's from his kind of change in mental status or even from the pain. I'm not really sure,
Or
but
just change in location, like having the freedom and the comfortability of living at home versus now being taken care of. Like that's
Right.
a big change in lifestyle.
yeah. So it could be due to any three of those factors, really.
I noticed this that he was preoccupied with pain there, like he's focused on this one thing, which I think was defined in one, I think it was the ATI mental health portion, where it said that moderate anxiety is defined when you start fixating on a single point, one thing that's giving you.
Yeah, I think that was information that we had to know for our first exam
Mm-hmm.
in one class. Okay. And the obvious hallucinations of his friend, that's definitely something that's relevant. What would be the significant? I mean, he's hallucinating, but like, do we know why he's hallucinating? Is that something that dementia can cause, or is that more like delirium? Do you guys know?
From what ATI was laying out with the difference between delirium and dementia, it definitely leans more towards delirium as causing the hallucinations, whereas the dementia you have focus and attention problems, but you might be delusional as to like thinking that you're at home when you're not, but you're not hallucinating, you're not psychotic, you're still in a version of reality.
Right.
Yes.
What else for this category?
Potential self-harmers.
Yeah. And he's not oriented fully, he's only oriented to person and place. Again, that just indicates that he has an altered mental status. Okay.
He's definitely frustrated.
Yeah,
Yeah.
for sure. Alright, anything else we'd like to add to that section? Or do you think that's good?
I think that's good.
Let's look at, I think it's the general appearance and respirations
I
next.
think it's just a general assessment's the next thing.
Okay. So it looks like general appearance, he is calm, body relaxed, no grimacing, appears to be resting comfortably. Respirations, breath sounds are clear with equal aeration bilaterally, unlabored respiratory effort. Cardiac, pink, warm and dry, no edema, heart sounds strong and regular. S1 and S2 with no murmurs or abnormal beats. Pulses are 3+, equal with palpation at radial, pedal, and posttibial landmarks. Brisk, cap refill. Neuro, oriented ×2, has some difficulty falling asleep and waking up at night. GI is abdomen flat, soft, non-tender, bowel sounds are audible in all 4 quadrants. He voids without difficulty, but is incontinent of urine, reports that he just changed himself. And skin integrity is intact but tinting the skin. So out of that, what's the relevant assessment data?
Skin things stick out to me.
Yeah,
Definitely.
totally.
Especially when you put it together with the 3+ pulses, like his heart is definitely having a problem pushing around the fluid that he has
So in terms of significance, I think I remember reading in our pathophysiology book that that's indications of a fluid deficit, right? Okay. And he's having some sleep disturbances, which again just shows alterations in baseline.
Yeah, they're definitely not good. I feel like he might. I feel like he's sitting at COPD. He might do that.
Oh, okay.
I don't know if that's outside. It doesn't say that it's outside of normal.
Yeah.
That's
It
fair.
doesn't say that it is normal, so I feel like it's definitely probably as part of this. It's definitely clinically significant. However, I don't know if that's something that's
Probably some
changed.
further assessment on what's normal for the client.
100%.
Yeah.
I would say probably the same on the pain rating, just from the general appearance here. Like he's calm, his body's relaxed, there's no grimacing. Like maybe a 4 is his baseline, and he's always there. So we want to get a little more information on that.
Yeah. Okay. Anything else?
Touch on the incontinence yet?
Oh. Oh no.
Doesn't look like we
I
did
don't know
that.
if we
I
No.
don't think so.
We talked about it before,
Yeah.
Yeah.
but maybe not just
But it's
now.
relevant
It's
here
definitely
too.
relevant, yes.
Yeah.
Because it could be, does he have bladder control issues, or is it a neuro thing that he's not realizing? So
Interestingly, I think it's kind of both because they're saying he's incontinent with urine. We've got urine-soaked pants, but he's saying he just changed himself.
Yeah.
So you kind of have, he forgot that he changed himself and then urinated. He doesn't even know that this happened.
Right.
So it's kind of a multifaceted problem with that.
Okay. Agreed. All right. Lab results are next. So we have the most recent sodium. They're hanging out at 140. His potassium has gone from 3.4 to 3.5. Wait.
I think it's actually the other way.
It-
So most
okay.
recently,
Yeah,
it's again, but
3.5.
currently, right now, it's actually
It's
trending
actually
down.
down.
His potassium has decreased,
Okay.
which makes sense if he's voiding of urine. Potassium follows it; it's going to come out. So I would expect it to be that way.
Okay. And then reading it that way, his glucose would be 182 to 225. So he
Yeah.
has an increase or worsening glucose. And then I always mess that word up.
Creatinine.
Creatinine. This is from 1.1 to 1.2. Do we think that's significant or?
It's definitely worsening, right? Higher
Yes.
creatinine means your kidneys are not functioning.
But if it's within range, then it's not significant.
Okay.
Just because it's a change doesn't mean it's
True. It's something to keep an eye
bad,
on. I feel
or,
like
right?
the trend is something to watch.
Sure.
Keep an eye on it, but right now we're really just looking at the potassium and glucose, right?
Glucose,
Yeah.
yeah.
Okay.
Definitely,
And they're both worsening.
yes. In opposite directions, apparently.
Yeah, one going down, one going up.
Okay. Anything else we want to add for that? Did we talk about the clinical significance? Just that it would hyper.
Well, I mean, just like we just did saying like
Yeah.
they're going in opposite
Okay.
directions, but yeah, we could put a label on it and say that, you know, that since the potassium's going down, it would potentially be hypokalemia.
Mhm.
If the glucose is going up, it could potentially become hyperglycemia.
Okay.
So,
It just means his fluids are changing, right?
Yeah.
Definitely. Kind of tracks with the dehydration.
Sure.
All right. We have more labs. White blood cell has gone from 5.8 to 6. Hemoglobin has gone from 14.5 to 15.2. What are PLCs again? Platelets, thank you. 198 to 202% neutrophils, right?
Mm-hmm.
52 to 55, and then no change in what's the last category?
Bands. Just the difference in like the immature versus the mature neutrophils.
Okay, cool. Relevant data. Okay. What are we thinking?
I mean, it's all,
Well, basically,
yeah, it's all,
It's all within an expected range.
Yeah.
but it's all going up.
It is all going up,
Mhm.
and specifically the neutrophils are going up, which means that that's your body's from the patho textbook from last semester. I remember that was like, as soon as neutrophils goes up, that's like the first line defense of when your body's like, yeah, I have an infection, give me a bunch
Right.
of neutrophils.
Something's wrong. Yeah.
Right, so something's starting to happen with that.
so they're stable but trending upwards. Like clinical significance is there's possibly an infection that's starting to develop.
Yeah.
Okay. All right. Okay. Last lab values we have are his urine is yellow, clear. Specific gravity is 1.0 1.05. Hasn't changed much. When they last checked, it was 1.018.
0.01.
Yeah.
Thank you.
It's changed by 0.003.
Yeah.
Proteins negative, nitrates negative, LETs negatives, red blood cells 0, white blood cells have increased to 4, and there was trace bacteria and a few epithelial cells.
Yeah, it's definitely a sign of
Yeah.
Thinking
Same.
infection,
Sign of infection,
UTI,
yeah.
What's relevant?
White blood cells and the
yeah,
bacteria. Yeah.
Obviously.
and they're
That
worsening.
sounds very, yeah.
Yeah, I don't know how that. A lot of scales when you do the UAs, it only goes to 4. Like you read it and it's like 4 plus,
Okay.
or 1 or 2, and it's like considered a range. Like when you look at the actual strip, so the actual strip saying 4 just means it's a very high level of concentration. Like they don't know how high of a concentration.
Right.
It's just a significant
Gotcha.
amount. A definitive reading.
Because I'm assuming if you have an infection, those numbers could get pretty high, right?
Yeah, it's kind of like it's not like when you do a blood draw and you actually get a number, right? You get the 10,000 or whatever. It's like
Yeah, because I was gonna say 4 red
it's
white blood cells.
4 is like if you think of it like it's the same as like you're doing a pregnancy test, like a strip, right? You have like a result, like you have a positive amount or a negative amount. This is saying there's a positive amount of definitive white blood cells
Yeah.
in
Got
there.
it. Well, what do we think is going on altogether? We kind of touched on it. We definitely know there's an infection, but it's urine, so UTI.
Yep.
Okay.
And then that's now causing delirium.
Yeah.
Delirium.
I remember in one of our discussion posts, we talked about how delirium kind of causes inflammation and can affect the brain, right?
It's the infection, yeah. So in the elderly typically, when they develop a urinary tract infection that they don't know that it's there. They don't get the typical things that we get, the painful urination, the frequent urination. They don't report it like we do. They just become incontinent, which is the frequent urination. You see that, but they can't really feel the pain. Like those things are different, so we don't catch it until too late. By the time you catch it, the inflammation is now instead of localized to their bladder,
It's all
and
systemic.
it's systemic. It's all over, right? So now you've got inflammation everywhere, and the cytokines, the products of inflammation,
Those
are
can
what
cross the
those
blood
cross
brain.
barriers and go to your
Yeah.
brain and actually start affecting your brain chemistry, which is what causes his agitation and his hallucinations and all of that stuff. At least that's what Caviardi was putting out in the past we'll get into. And all the discussion posts we
Okay. So in terms of like, it asks for primary concept. Would that just be like infection and cognition? Those are the 2 things we're dealing with here.
It seems like there's the health related. I honestly don't know what health related concept means, but it seems like if you think about the
You erased my comma.
Oh, sorry.
anyway, yeah, it seems like whatever if you think of the health related concepts, his infection is health related, and his cognition is health. Those are the 2 things they're having an effect on.
Yeah.
Okay.
It would seem.
Good stuff. So next up we have medical management. On the left-hand side, it lists some things. We have a neuropsychiatric evaluation, urinalysis, haloperidol, acetaminophen. Those are orders. Insulin glargine, increased memantine,
Donepezil.
donepezil, and trazodone. Well, just looking at the meds from our pharm class, that was I think it was the NDH handbook. I recognize those. I know the acetaminophen will be to treat the pain and possibly bring down his low-grade fever. And then most of the psych meds are dementia management or like helping to almost sedate, right? So bring down
The
his
memantine
agitation.
and the donepezil, are the ones that are going to affect the dementia. The haloperidol is the trade name is Haldol, and that's really good as an antipsychotic. So hallucinations.
And the trazodone, that's more of a sedative to help with agitation, right?
And the anxiety,
Yeah.
typically helps us sleep. At least that's what the engagement is.
We touched on the urinary analysis a little bit already, but
Yeah.
looking for signs of infection, dehydration, kidney problems.
Worsening.
Yeah.
And then the last is the neuropsychiatric evaluation. That's just, seeing if the patient's cognitive state has changed at all, right? Okay.
I can do certain assessments that you can do that will help figure out
Like
if this is-
spices and CAM and, okay.
figure out if this is delirium or if this is just something else. Which, maybe if he's got some sort of mental health, but that's diagnostic criteria. Figuring it out.
So basically, we next have to figure out like the expected outcome is from all of this. What are we expecting to see in this specific patient?
From all this, I mean, we should be able to determine if there is an actual infection. We should be able to determine what we're going to do about it.
Decrease the patient's pain.
We're going to affect his pain, and in theory, we should help his anxiety and help him sleep a little bit better. She's not doing that. The energy times should help him sleep doing that. Now we got to get his blood sugar down. That's the point.
All right. Next is collaborative care nursing. So nursing priorities. What are we gonna do with all this information? So like this is gonna be our nursing interventions.
Skin assessment,
Yep, I agree.
because he's in wet pants.
No good.
And probably unable to communicate to us if he's feeling like if his butt is sore or something.
One is
So-
skin is tenting, and we've already got decreased elasticity and age, and then you add dehydration. It's just a recipe for skin tears in all kinds of.
Especially with dehydration and then also soaking it for a prolonged period of time.
Yeah.
Yeah, not good. So
I'd be concerned about him falling. So definitely do like the fall risk assessment, implementing whatever policy is at the specific place to make sure he doesn't have falls.
I think I touched on it earlier, but the pain assessment as well, like kind of find out what his baseline is, if 4 is abnormal, and then how do we improve the pain assessment there. And you guys just touched on it too, as far as the agitation, impairing his healing, his communication, and all that. So make him comfortable, give him a good environment to
Get better
get better
at what that 4 actually means.
Yeah,
Right.
exactly.
Okay. So basically the outcome for all this, based on what we all said, is just we don't want them to fall, we don't want them to have any further skin breakdown, and we don't want them to have any increased pain levels, right?
for
For
sure.
sure.
Okay.
Yeah. For our shift, obviously, we have to be specific about it.
Okay, yeah, that's
Timeline.
right. All right, psychosocial priorities, so this is nursing interventions, but psychosocial wise. I think I kind of mentioned them earlier, but the CAM and the SPICES assessment is definitely something we want to include to monitor for like mental changes.
Yep. I think we can do a suicide screening, and this is from past experience, but I know the home-based suicide severity risk scale is actually a really good tool to use with patients that make these kind of statements. Because I would guess that he's probably just frustrated based on that thing, but
Well,
I would
and
definitely want to ask him some further questions to see where his mental status is really at, because that anxiety really could be causing a problem.
I think ATI mentions that that's a good resource too to use, and it kind of, I remember we did one module where it walked us through like the indications that we might have to use the screening, so I totally agree. I think we need to be good at just using like therapeutic communication,
For sure.
because this person's agitated, like doesn't really want to be here, so we just have to, create that safe, comfortable environment so that it doesn't exacerbate anything he's feeling.
Yeah, and that's always a good practice with mental health concerns.
I'd love to do a cultural assessment with him. I just feel like there's probably some pieces in there that aren't being addressed. I'm missing a lot of information, but based on some of the information, I'm pretty sure he's better, which to me means there's probably something going on that could be helpful for him, particularly over other people who might have a specific need
Right.
that we can meet.
Yeah, we don't know even if he's like religious or if he needs any support in that way, so I totally agree. Well, what's our outcome with these interventions? Just in general.
I think they all kind of relate to the same idea of comfortability and giving him a therapeutic environment, really just to help lower that agitation and decrease the frustration he's having with the facility in general at the moment, because he clearly doesn't really want to be there. So,
Improve some positive communication so we can get some real, true assessments done.
yeah.
Awesome. And last part is education. What do we want to educate this patient on? I think medication management, I want to say, is number one, but I know that with, the patient does have dementia, so this is not only going to be the most important thing to educate him on, but also probably the hardest thing to maintain and like develop a system for.
But we shouldn't be just educating him, we should definitely be including his wife,
That's a
especially
good point.
because she's taken over,
His medical decision making.
Decision-making,
Yeah,
okay.
she's the guardian.
So medication management teaching for him and the wife, so they're both included on that.
It's, you know, I noticed there was something kind of back up here, and you know, he said that he's been buying takeout food. His wife would bring him takeout food, and then he'll eat another dinner. So we should probably do a diet management program as well. So I talked to him about when to eat, and educate his wife on, hey, we provide him food here. Please not bring him extra food, because that could be causing some of the problems with his blood sugars. You know, sugar in a
Totally.
milkshake, and we don't know about it,
Yeah,
right?
that's a good point. Yeah, definitely educate on diet. Anything else?
I think general safety, safe ambulation. You know, he expressed that he wants to get out of the facility, he wants to go hunting, he wants to do these things. So educating him on, you know, how to get up and move around in a safe way. If he needs to use a call light, you know, how long does he use the walker? It said he has one. Does he know how to use it? Make sure he knows that, and then also educate the wife on, you know, keeping the space, you know, free of clutter hazards to try and increase safety.
I bet that'll help his mental state, because just based on what I'm seeing, you know, he's talking about he's wanting to go hunting. He was in the Navy. He was a salesman for 35 years. He was probably on his feet a lot.
Yeah.
So I bet like movement for him is important. You know, that he's not moving could be one of the things that's affecting his anxiety and agitation.
And adding on to what you said with the diet, like he needs to have better fluid intake too. Probably, like we don't know.
Yeah.
Like, is he just getting water through milkshakes? Like you said, we don't know any of this. So
He could not be drinking water
Yeah.
at all.
he had skin tinting,
Mhm.
so he's obviously some form of dehydrated.
dehydrated. So educating him and his wife on adequate water intake would be good too.